Good afternoon. I'm Another View producer, Lisa Godley, sitting in for Barbara Ham-Lee. Today we're discussing a topic that has probably touched your life or the life of someone you care about. I'm talking about cancer. Today's discussion will focus on the lower region, specifically prostate and colorectal cancer. The number of African Americans who die from these cancers each year is frightening, but it doesn't have to be this way. Join me and my guest, Dr. Keith Newby, oncologist Dr. Lloyd Shabazz, and cancer survivor Charlie Hill, as we dispel the myths, discuss the treatments, and answer your questions about prostate and colorectal cancer. Another View is next, right after this news from NPR.
Discussing the issues and celebrating the successes of the African American community. This is Another View.
Good afternoon. I'm Another View producer, Lisa Godley, filling in for host Barbara Ham-Lee, who's getting an early start on celebrating her birthday. So happy birthday, Barbara. And as always, I'm going to do my best to make her proud. When I first read the numbers regarding prostate cancer deaths in Virginia, I was stunned. Yes, Virginia, with all the medical facilities, healthcare professionals, health fairs, and free screenings, we still have one of the highest prostate cancer death rates in the nation. And African American males are twice as likely to die from it than their white counterparts. And when it comes to colorectal cancer, the number for African American men and women is almost as alarming. So why is it when, as Barbara and I always say, when everyone else catches a cold, the African American community gets pneumonia? Today we're going to talk about these cancers and what we can do to bring these numbers down. And to launch this conversation, we welcome to Another View cardiologist Dr. Keith Newby, who so graciously makes a house call to Another View, our studio, the fourth Friday of each month. Welcome, Keith.
Thank you very much.
Cancer warrior and good friend of Another View, Charlie Hill. Charlie, thank you for being here.
Thank you.
And joining us by phone a little later in the show, oncologist Dr. Lloyd Shabazz. Welcome, everyone. Now, before I ask the first question, I'm going to throw out the numbers. So if you have a question or a story you'd like to share, you can give us a call at 440-2665 or 1-800-940-2240. Now, guys, I'm going to start with a personal story. I know when I have a mammogram, and I know we're focusing on the lower region today, but when I have a mammogram, I know I always try to schedule it not around vacation and not around the holidays, because I guess like the Wicked Witch from The Wiz, don't bring me no bad news. So I always try to do that. And I'm wondering if fear is part of the reason that the numbers are so high when it comes to exams for prostate cancer and colorectal.
Well, I would say in any situation, fear is always going to be a major factor, because the term cancer, for all intents and purposes, signifies death in a lot of people's mind. And even though we may see that the cure rate for a lot of these things is high these days, I mean, but that's not what you hear, and that's not the stigma that it carries. So I think when you start talking about, even in my field in cardiology, I will get less fear factor with somebody coming in with a heart attack than if somebody told them they had cancer. So, it's really one of those situations where I think just that word or the concern or even the possibility evokes so much fear, it does shy people away. No question in my mind about that.
I agree with that analysis. I do think, though, that maybe the major contributor to our situation is the fact that we don't go to the doctors early enough to be successfully treated. And as a result of that, when a man presents with prostate cancer, it's usually advanced. And I think if you start with an advanced prostate cancer diagnosis, then you're going to more than likely lose your life. So I think that is the link, just simply not being detected early enough. Yes, fear is there, but I think in the opportunity is to focus on awareness and education.
Okay. Charlie, I would like for you to take a moment and share your story with our listeners, because you're two-time, as you your word you use is warrior of prostate cancer.
The reason that I'm a warrior is that you can simply be a survivor and do nothing. I like the idea of being a warrior because a warrior suggests that you're going to be active. You're going to do what I'm doing now. You're going to share your story. You're going to provide information to help other people. When I was diagnosed in 2002, I could not find more than 2 people who even heard of prostate cancer. No one in my family had mentioned or knew about prostate cancer. So I went outside of the family circle, and I couldn't find hardly anyone to talk with. I ended up in Baltimore at Johns Hopkins because I had doctors up there who claimed that they knew a lot about prostate cancer. At that time, they offered themselves as the gold standard for treating prostate cancer, so I was subsequently treated there. That experience of not finding anybody who would talk with me, who knew enough to help me other than my local urologist, was an experience that I said, in future, if I can do something about that, I will not let that happen to another man. So my story starts with the challenge of being diagnosed. I was not afraid because frankly, I was more surprised. I didn't believe. I had 3 opinions because I didn't believe it was true. I had a normal PSA, and I had a normal digital rectal exam.
Wow!
And so I just didn't believe it was true. And as a result of that, when I became convinced that it was true, then it became important to learn what else was going on with me that would have this particular result.
Okay. All right, Keith, now people are listening to Charlie's story, and I'm sure they're sitting at home wondering, okay, if they don't know a lot about this, where do you start?
Well, I think the first thing is always, your doctor visits. One of the things that Charlie mentioned earlier, which I do agree with, is the issue of people going to the doctor. But, a lot of why people don't go to the doctor, a lot of that's fear, again. Fear of the unknown, and then pain. Now, let's be real. You go to the doctor, he's going to give me a shot. He's going to do this. You think about when you're a kid. You hate going to the doctor because you're going to get a vaccine. You're going to get this, that, and nothing feels good when you go there. In the end, and probably majority of the time you go there, nothing happens that does hurt, but it's just that concern that you have. So the first thing is always getting to the doctor. But then men have this thing about the digital rectal exam. A lot of men, I don't want somebody doing this to me and this, that, and the other. And so that part gets back, they back off of that. So a lot of this stuff is preventable, if you ask me. I mean, if you really think about it, cancer treatment is all about early detection and implementation of whatever the treatment strategy may be. And that's where, we fall short, I think, as a people, is that, we don't do the early detection. And that's when you first start at the doctor's office. If you're noticing something that's different, I ask people all the time, like if I'm asking about chest pain, they say, well, I don't have pain, I have pressure, I have this or something else. And I'm like, well, bottom line, whatever you're feeling is not normal, for you. So that's what I'm focusing on. It's not so much the defined term, but what's different from what you used to be. So if you're having trouble like urinating or, some issue, or you see a change in the color of your stool, that ain't normal. I mean, let's just be real. And because it's not, that is the time that you should be seeing a doctor once a year anyway. I mean, because the more you're doing that, the higher the likelihood of that early detection. But trying to get people there is where we fall short. Okay.
Go ahead, Charlie.
It's important to note that early stage prostate cancer that's localized has no symptoms. So, and I agree with what Keith has spoken about, but there will be no early signs. I didn't have any signs.
I was about to ask about symptoms.
And that's extremely important, that if we're waiting for something to happen, pain or bleeding or something falling off, that won't happen in the early stage of prostate cancer. And that is another reason why it gets so far ahead before it's detected.
Well, I was actually kind of curious to ask you a question, because you mentioned, I don't know if I misheard your comment about you had a normal PSA and a normal digital rectal exam. How did they find it?
because my dad had a heart attack at age 55. As a result of his heart attack, I was encouraged to be aware of my cholesterol level, triglycerides, and other numbers. And one of the things that I did was I captured data, and I was writing down these numbers, and I was writing down PSA values, and what I saw was a trend.
Trend upward, okay.
And that's extremely important. It was the trend that led to the biopsy that confirmed that I had prostate cancer.
All right. So it wasn't that it was within an acceptable range, but there was a trend upwards.
Yes.
Okay, I'm with you now, because I was sitting there saying, how the word did he find that? But knowing you, knowing how proactive you are, I can see that happening.
And that's extremely important. One of the messages that I want to share is that we have to be proactive. We have to know our numbers. We have to know our medical history. We have to keep records.
Well, and that's something interesting too, especially when you're dealing with African Americans, because a lot of times we don't like to talk about, I'm going to use my own family as an example, we don't like to talk about what has happened to somebody in history in the past. So you really have to sit down and have that conversation, because otherwise you would know that your great grandfather, passed away because of this if it's not talked about. And a lot of times it's not discussed. So those conversations are very important.
And that's why your show today is so important. This opportunity of talking about colorectal and prostate. I do probably 50 or 60 sessions a year. I have more than half of those sessions, somebody will say, well, I did my colonoscopy, and so I don't need to worry about my prostate. The connection, no connection. I mean, other than the region of the body, no connection. So there are people who think a colonoscopy will provide information about that a digital rectal exam would provide.
Wow.
So we're talking about awareness and education. If we can nail awareness and education and have more people, particularly women, to understand how you diagnose prostate cancer, what you need to know, we can move the meter, we can diagnose men early enough to save more lives and reduce these horrible mortality rates.
Because the women are going to make sure
because
their
the women
men get to the doctor.
The women have these tremendous investments, and what I would like to say is that it's awfully selfish of a man to say, well, I'm not going to be bothered with this prostate thing, when if he is diagnosed, who's likely to take care of him?
The woman.
So I would say to the women, get involved, understand, because you may have to be dealing with a man who could have prevented some of this, or certainly he could have caught it early enough to have had a better outcome.
Okay. Are there specific ages that we should be targeting these tests? Charlie's raised his hand. He's ready for this
For
one.
high-risk men, and let me define high-risk men, and those are men of African descent and men who have a family history, age 35, and that's the most aggressive standard in the world, age 35 for high risk. And that has been a position established recently or last year by the 100 Black Men of America and other groups that I work with. And the reason that we have this aggressive standard is this. On May 3rd of this year, the American Urological Association announced clinical guidelines for average risk men, average risk. And in their release, they said, we don't have clinical guidelines for men at highest risk, men of African descent, men with family history. And what that really means is that it's the luck of the draw. If you go to a doctor who's not enlightened and who's not informed, like Keith Newby, you may be in deep trouble even going to a doctor, because there are no guidelines, and most people are surprised by that, and that's why we have this aggressive standard. Now, once there are some clinical guidelines available, then perhaps those standards may not be, we may not be as aggressive. But I would say that if you have African descent or if you have a family history, you should start annual early detection activities at age 35.
Wow. Okay. So we need to start a market campaign toward the women.
Absolutely.
to get their men to the doctor.
Yeah, some of the downsides, unfortunately, so with some of our men is that I've seen the fights in the office when the wives trying to get the husbands to do something, and depends on the individual male. I've seen almost cat fights in the offices regarding these issues, and it's kind of one of those things where I throw the same philosophy to men. I say, just remember now, when you take this particular stand, when I'm talking to them, I'm speaking on heart things, and I'm saying you take this stand of, I'm not worried about it, and my family be all right. I'm like, you don't know they're going to be all right. You got married, you start having children. You're not your own individual anymore. You have obligated yourself to your family, and you can't take that selfish position. Right. You have to take a position that, these are individuals that you have chosen to align with. I mean, your wife, your children. I guarantee your wife didn't propose to you, you proposed to her. Children didn't ask to be here. Majority of the time, children came because you decided to do that. And because you've taken on that responsibility, you have a higher task to make sure you're around, to make sure they're cared for.
Okay, let me make a quick announcement. Sure. Dr. Shabazz has sent me an instant message. He had an emergency situation just happen, and he's hoping to call in before the end of the show. But if he doesn't, he's really trying to work it out because he really wants to join the conversation. But he did have an emergency happen. I know he's one of the busiest men in oncology because he had finished his day, I think, last night about 9 o'clock when he called me. So I know this is something that requires a lot of time, and we appreciate and we hope that he can make it in. If you have a question about prostate or colorectal cancer, if you have a story you'd like to share with us, just give us a call. The number is 440-2665. That's 440-2665 or 1-800-940-2240. We look forward to answering your questions as best we can. Now, colorectal cancer, same time frame? When is that exam supposed to take?
Well, they say with that, the kind of average scenario is less than 50. I mean, if you're 50 or higher, you're supposed to be getting these annual exams. And, and really a lot of that becomes, I think if you have a family history, strong. When I say family history, I'm not talking distant relatives. I'm talking first degree relatives, mother, father, brother, sister. You have to really be kind of on it. And a lot of times they're even going less than that, 45, sometimes lower than that in certain situations. But I always look at it, that one, you really want to make sure you're getting your blood occult stool samples done, because then if there is any signs of occult blood in the stool that you may not visibly see, that's going to instantly lead to a colonoscopy. And then you can see pops or whatever and start really getting into that and start to get that early detection. And that's really something that we really need to be on top of as well. Cancer, especially with colon cancer, I've seen more deaths with that. It's scary to see. So, that's one of the things we really want to push the envelope for.
Wow. Charlie, any input?
Yes, I think we can put a finer point on the prostate family relationship as well. First-degree relatives, father, son. Father, brother. If your father had prostate cancer, if your brother had prostate cancer, that's a first-degree relative. That is a very high-risk situation. If you have other relatives who had prostate cancer, in our community, we'd like to simply say, wrap your heads around family so that you can have that family conversation. But the risk is highest if your father or if your brother had been diagnosed with prostate cancer.
One of the things that I did want to go ahead and bring up, because Charlie and I talked about this right before the show started, was diet. And since we have an opportunity, or do you want to go ahead and take this? Okay. One of the things I want to bring up is this diet issue and how that can prevent, especially in colon cancer, prostate cancer. I'm not as astute on in that regard, but I know colon cancer, they're really kind of beating us up, being as physicians, to make sure we're informing the patients to get away from these high-fat diets. They say that if you're eating more fruits, vegetables, less meats, red meats, that your risk of cancer does go down. And I do believe that to be true. You find less polyp problems in the colon when you're eating higher fiber diets, and that is true. That's the same thing for even with heart disease. So that's one of the big things we look at is low carb type. Low carb, low-fat, high protein diets.
Now, I read somewhere, I think, about sweets, too. If you cut back, you're supposed to cut back.
Well, that's the carbohydrate content. So those things can really, those high sugary kind of, unfortunately, so the problem I went into, and same thing with heart problems, is what's the cheapest thing out there. If you're a family of limited means and you look at, well, what can I do cost effectively to feed my whole family, you'll find that, unfortunately, it's going to be high fat, low protein, high carbohydrate diets are the cheapest thing out there. I can get a big thing of sugar for like $1, But if you look at getting, some one of these different types of artificial sweeteners that are a little bit more healthy for an individual, it's going to cost $1 gazillion. So you're looking at, when you got a family of limited means, I mean, these are the issues that are true to force. That's why I always tell people, listen, you got some space in your backyard to put a garden in there, you can start growing your own things, start doing that. I mean, it's cheaper to do it that way than anything else.
Let me take a call. We have a caller, John, from Williamsburg. John, you'd like to share your story with us?
Yeah, good afternoon. Just got in the car at lunch, so I haven't followed the whole conversation, but I got part of it was that, men are reluctant to go do what they got to do about getting an exam. A lot of times that's because there is the infamous digital rectal that has to be done, as we called it in the Army, the finger wave. And a lot of guys are reluctant to do that. I was on flight status for about 20 years, so I had that done every year after 40 by the Army. And then I got out and told myself I was going to keep the same standard. Had a little trouble finding a good general practitioner. So about 3 years went by, and I decided, hey, I probably need to get back in there. So I went back in after 3 years of not having a PSA screening and racked up a PSA reading of 6.8. Went in for consultation. Biopsy gave me a Gleason score of like 7, and I was in pretty bad shape. However, if I had waited another month or two, 6 months, there would have been no good answers. I wound up having to have a radical prostatectomy, and I'm doing fine now, and it looks like I'm clear. That was 5 years ago.
Wonderful. That's good news.
Yeah, it was great. I mean, I was very lucky, but I just want to let guys know that, the alternative, had I waited a little longer, and I was somebody who was fairly diligent about that, but, the day I didn't go in for that exam that year, that's when the cancer said, okay, I got you. And the suffering that I know that I've seen in other people who have had prostate cancer, it is a horrible way to go if you don't catch it in time. So, guys, I'm telling you, I don't care what the media says. Well, some of these biopsies are unnecessary. We're only identifying 1 out of every 10,000. Well, I'm number 10,000, and I'm pretty glad I did it. So I just wanted to share that.
Just out of curiosity,
so much, John.
was your cancer confined to the prostate itself? Had it spread outside of the prostate area?
No.
Okay.
No, I was very lucky, doctor. First thing they did was they ran a bone scan. Because as I understand now that different cancers have affinity for different parts of the body.
Correct.
And in prostate cancer, it tends to go to the bone marrow. So I was very fortunate. When I did have my the prostatectomy, he did have to take some of the surrounding tissue, and about half of the nerve back. And, so there were some issues with that. But, hey, I get up every morning.
Yeah,
I'm still able to kiss my wife goodbye in the morning and play with my grandkids. So,
that's great.
Yeah. And had I gone in a year earlier or 2 years earlier, if I hadn't missed that one, I would have had better options. But I'm still thankful for the fact that I've got again, 4 years of being cancer-free. So I consider myself very lucky.
Right.
Okay, Charlie.
John, I'd like to induct you into the Warrior Brigade because telling those stories make a huge difference. And I appreciate you sharing your story, and I hope other listeners will take from your story enough to do something about their own situations.
Yeah, they sure should. It's really not that big of a deal, once you get used to it. And I don't know your feelings on it, but even if you just get the PSA screening and they don't do the digital rectal, but that's up to the doctors. But to me, that's what caught it for me. It was that PSA screening, and nobody's ever going to tell me that's a waste of time and money.
Well, I do have a thought about that. I think you have the companion, both the digital as well as the PSA.
And again, being in the military, having it done every year, it was second, nature to me. I didn't have a problem with it, but I have definitely gentlemen that I work with, a lot of reluctance out there. Well, I'm not going to do that because they're going to want to do a digital rectal and say, hey, pal, it beats dying from cancer. So put up with the indignity. It's just you and the doctor, and you go about your day, All
right. Thank you so much, John. We really appreciate your call, and we appreciate your sharing with us. If you're just joining us, today's Another View on Health. We're tackling the topic that has probably impacted you or someone you love, cancer, specifically prostate and colorectal cancer, with cardiologist Dr. Keith Newby. We are hoping that oncologist Dr. Lloyd Shabazz will be able to free up from the emergency he's been called to and give us a call a little later on. And cancer warrior Charlie Hill. Now, if you have a question or a story you'd like to share with us, just give us a call, 440-2665 or 1-800-940-2240. We have Bob calling us from Virginia Beach. Bob, thanks for calling.
Yeah, I wanted to share my story also. I developed prostate cancer in 2004, and I had a Gleason 6, but mine had subsequently found out that it had gotten out of the prostate. And so what I had to do was I had to decide that, of course, I too was going to one of the two best urologists here in town, but they put me on something just to take away the testosterone, which I didn't think was enough. So I searched the country to find someone who I thought was a prostate oncologist, and came upon Dr. Charles Myers, who's up in Earlysville, Virginia, and he's known as one of the best prostate oncologist in the country. He also was director of cancer research at UVA. So I went to see him, and I just wanted to share that with anybody right now who's dealing with prostate cancer. They could contact Dr. Myers, and I could give them the phone number at 434-964-0212. And if he is also associated with a big cancer research center down in Florida, a radiation center down in Florida. So I think if anyone who's suffering from that right now, they should make that effort.
Okay, Bob, thank you so much for your call. We really appreciate the information. We have Frida. Is this Frida Bryant?
Yeah.
Hello.
Hi.
Line 3. Hi, Frida.
Hi, Charlie. Hi, Dr. Newby.
Frida, how are you?
In. I'm well. Was taking a lunch break and tuned in, and I tell you, Charlie is such a warrior, and I've known him for years, and I just applaud you, and I appreciate you for everything that you're doing, and you're so right. If we get our women involved, then I think that we will move the meter that needs to be moved. I just wanted to call in and tell you how much I appreciate you and how good it is to hear your voice, my friend.
Well, Frida, thank you, and I want to make this point. Frida is a breast cancer thriver.
I know, she's wonderful.
And I'm motivated and inspired by her.
All righty. Frida, thank you so much for calling in. We really appreciate it.
Have a blessed day.
I understand. You too, sweetie. I understand we have Dr. Shabazz on the phone. Good afternoon.
Good afternoon. How are you?
I'm great. Is there anything, I know, and I really appreciate you getting in with us, is there something that you want to share? Because I don't know how long you'll be able to stay with us, with our listeners, regarding colorectal cancer.
Well, yes, colorectal cancer is it is the third leading cause of cancer mortality in the country, in both men and women. And my message is that when people reach the age of 50, they should definitely heed the advice of their primary care physicians and get their screening colonoscopy, because the only way that we can impact this disease is if we catch it early. Too often I see patients who are coming in their 60s and early 70s, and they tell me that they have been feeling fine, so they didn't feel the need to go in to have the colonoscopy. And lo and behold, now we have a cancer that's stage 4 when it could have been caught in the precancer stage in the form of a polyp. That is a reason why we encourage people to do the colorectal screening. So my advice is to go and get it checked.
Okay. All right. Were you going to say something,
Well, I just
Keith?
want to have a question. Hey, Dr. Shabazz, Keith Newby, how are you?
Hey, Keith. Fine. How are you?
All right. Listen, just out of curiosity, from a cardiologist perspective, who doesn't do this particular kind of treatment on a day-to-day basis, when I listen about the issues of prostate cancer, I've always felt like I have so many mixed reviews in terms of how to best approach that particular diagnosis. And when I say that, meaning when you do active surveillance versus, active treatment. Now, I know, of course, if it's extending outside, if it's gotten to a very high Gleason score or whatever, you're going to be a little bit more aggressive. But what's your marker in terms of when you tell somebody that active surveillance is an appropriate treatment choice versus some of the other modalities that you all are doing, like the C's or whatever you recommend? What's your cutoff to say active surveillance is the appropriate choice versus some active chemo or radiation or prostatectomy?
Okay, so we've changed now from colorectal, which was the first.
Yeah, I had to flip around. I'm gonna flip around all over the place.
Okay, yeah, that's a very good question. I mean, say for instance, I have a gentleman who comes to me who's 75 years old. He has a well-differentiated, slow-growing tumor with a low Gleason score. This is the type of person that I think the watchful waiting procedure would work very well for. On the other hand, if I have a 60-year-old or 65-year-old man coming in with a very aggressive high Gleason score tumor, I think the message there would be one should consider being a bit more aggressive. My recommendation would not be to consider watchful waiting in that setting because poorly differentiated high Gleason score tumors, they are very aggressive. So I think one has to look at the individual patient and all of the comorbidities that person brings to the table, look at the expected lifespan for the individual following the diagnosis. If we think that the treatment is not going to change the person's lifespan or outcome, then why put them to the treatment and increase the risk of taking away from their quality? On the other hand, if we feel that the treatment is going to be of a long-term benefit and the patient bring less comorbidities to the table, then that's the type of person that we would consider, or I would consider, being a bit more aggressive. But it's done on an individual basis. It's just not done globally. We have to look at each individual and what they bring to the table as far as, quality of life, how active they are, other medical illnesses that are going on in their life. And, of course, we look at the type of prostate cancer that they have. All prostate cancers are not the same. A Gleason 4 or 5 tumor is not the same as a Gleason 8. They act different. So that's my approach to that.
Okay. I'm going to take a call really quickly. Linda is on line 1 from Norfolk. Linda, thank you for calling Another View.
Good afternoon. I am a breast cancer survivor. I found out in 1999 I had a double mastectomy. I didn't have reconstruction. I am fine. I'm doing well. I'm very healthy. And I take a pill, though. This is my question. It's an Arimidex, and they told me originally that it would possibly have to be taken for 5 years, but now they say 10 years. So I'm a little bit confused. It gives me hot flashes. That's why I'm asking.
Okay. I assume that's for me.
Yes, go ahead, Dr. Shabazz.
Okay. All right. Okay, now we switch from colon and prostate. We're dealing with
breast cancer now, yeah.
Well, I think there's a little bit of confusion here. Recently at one of our large national breast cancer meetings, they discussed some data looking at tamoxifen and what would be the duration of treatment to get the maximum benefit. Years ago, there were studies done suggesting that one has reached the limits of benefit from tamoxifen at 5 years. So for decades, we would treat patients for 5 years, and then we would stop. And then a few years ago, we had some data showing that after 5 years, we could switch a person to one of the what we call aromatase inhibitors. These medicines work a little different metabolically than tamoxifen. You could switch a person after 5 years to an aromatase inhibitor for, 2 or 3 or 4 more years and get an added benefit. Well, recently, new data came out suggesting that we should be treating patients with tamoxifen for 10 years. And many people now are going to that recommendation saying if you've been on tamoxifen for 4 or 5 years, maybe we should go ahead and just continue it for 10 years. Some people are extrapolating the tamoxifen data to the aromatase inhibitors and are saying, well, if you're on an aromatase inhibitor such as Arimidex or Femara or exemestane, then maybe you should just stay on that for 10 years. And I agree. Most of my patients on these medicines do experience hot flashes. My more senior patients do not refer to them as hot flashes, though. They call them power surges. And that is a problem with these medications. There's just no way to get around it. I mean, if we can find a way to curb the incidence and the severity of the hot flashes, that would be a big benefit. But unfortunately, we don't have such medicines yet.
Wow.
Right. Well, I am 66 years old, so okay. I guess I may have been having them anyway, but you really did answer another question for me, because I knew that the other drug, the tamoxifen or whatever, yes, that was like the two choices that I had in the beginning, and for some whatever reason they gave me the Arimidex, and I had heard about the 10 years for the other drug, but this one, I kind of did some research on my own, and it did say 5 years. So now that you tell me that the information has been updated, that really did answer my question.
You're welcome.
Wonderful. Thank you so much for calling, Linda. We really appreciate it. Dr. Shabazz, I have a question for you since I have you on the line.
Okay.
I know one of the preventive ways is to have the colonoscopy. I heard someone tell me recently that, because people always complain about the liquid that you have to drink before you have the colonoscopy and how horrible it is. Mm-hmm. I've recently heard people say that you can take pills instead. Is that a viable option?
You mean as the medicines you take to
clean you out?
Clean up. Yeah. Yeah. Years ago, we had one way of doing this. It was with a medicine called Go Lightly. And probably 20 years ago, we would recommend that a person drink about a gallon of Go Lightly. You would drink it until everything started coming out liquid. Over the years, we've gotten more advanced now. We have pills that people can take that will actually cause bowel movements almost to the same degree that the Go Lightly did. But still, the liquid volume medicine is still very appropriate. Now we do a combination of pills with flavored forms of Go Lightly, if you will. But the volume is less. And now it's, maybe a quart, but with some pills. So that answer is correct. We now have pills that one can take to get the same benefit.
Okay.
But you can't really do the colonoscopy if you have not, gotten all of the fecal material out.
Right. Gotcha. Thank you so much. Let's go to Ronald from Hampton on line 2. Ronald, thank you for calling Another View.
Thank you. Appreciate all the information you're sharing about this very important topic. I have a question. I heard a program some while back where, as I remember it, the authorities said that the rate of sexual intercourse can affect whether or not men get a prostate cancer. And I just wanted to get any comments about that from Dr. Newby or Charlie Hill.
Let me ask you something, Ronald, before I toss this to Keith and Charlie. Was it frequent or infrequent?
Infrequent, I think, yes, rate. I think from what I remember was said that affects, whether or not you, it had some bearing on whether or not you get prostate cancer.
Well, I asked because I've heard it both ways. Yeah, so go ahead, Keith.
I'm gonna have a little bit of fun with this one because I want to pick with Lloyd on this one. Lloyd, we're gonna dump this one back on you again because we had a little debate about that question right before we actually went on the air, and Lisa brought that up. I have my own individual feelings, and I'll share them after. I want to hear what your thoughts are first, and then I'll chime in after that.
Okay. Well, I'm going to be very analytical with my answer. I do not have any randomized control study.
What did I say? What did I say?
Exactly what you said earlier.
Support it either way.
That's the same thing I said earlier.
That's some of the folklore that we hear out there about prostate cancer. Just like we hear the old folklore about if you have a cancer and you let the surgeon open you up and the air hit it, it spreads. You probably heard that one. Well,
Yes,
this is kind of in the realm of that folklore. We have no data. There have been no randomized control studies to suggest that one's frequency of intimacy has any bearing on whether one gets prostate cancer. So I have no data to support that either way.
Yeah, well, that was the same thing I said earlier, because I said the only way I said you would have to have so many patients in the study to try to prove that point. Otherwise, you have to have people in two different realms of living where you say, okay, this group, you're going to have sexual intercourse for X number of times, and then go back in time and tell that same group of people that they're not, and then see what happens at the end of down both parallel universes. And I would say you can do that. So I could hear how people could bring that up, but how could you ever prove that? I don't see how they ever could. So
I agree with you fully. Yeah.
So does that answer your question, Ronald?
I was hoping for a definitive.
Well, this is my feeling. If you like sex, go for it. You know what I mean? I mean, because I'll be honest with you. I mean, I think it carries. I don't see how it could ever carry any weight in that regard. I know that's a kind of a broad statement, and all I can tell you is that I agree with Dr. Shabazz on this one. There's been no data to support it either way. So to me, why change your lifestyle in fear of something without having anything? I mean, because I can go on TV and say almost anything, and make it sound like it's legitimized based on how I present it. But do you have actual information to say yay or nay? And nobody has that. So to me, and I've never heard anybody that either way. I've seen prostate cancer victims, who had frequent intercourse, and those had infrequent intercourse, and the same people who've never had prostate cancer have the same realm of intimacy, frequency. So I don't see. I personally, nobody can give you a definitive answer. That's the bottom line. But I would say if you like it, go for it. Charlie?
Ronald, I would agree that if you like it, go for it. I would say to you, I have seen it and heard those comments as well, frequent and infrequent. What I would point you to is that there are other risk factors that you have control over, and there are four that I would like to highlight. One is high-fat diet. You can control that. Excess weight, the lack of enough vegetables and fruits, and the lack of vigorous exercise. Those are things that I think we can get agreement on, that which you can control. And if you can turn your attention to that may serve you better than trying to get an answer to the frequency or infrequent sexual activity.
Thank you so much.
Thank you for calling, Ronald. We really appreciate it. Dr. Shabazz, that's something, too, that I often hear men talk about as far as treatment for prostate cancer. If they're diagnosed, the treatment, what impact that may have on sexual activity. Do you have any input with that?
Well, yes. I mean, some of the treatments have a somewhat of a negative impact on one's ability to perform. Some of the surgical procedures and even some of the radiology procedures can interfere with or cause erectile dysfunction. And some of them are temporary, and some of them are more long-term. But we also tell people that if it does happen, to talk with their physician about options of managing it. I mean, we have pharmaceuticals now, we have prosthetics now, and there are a whole host of other options that people have to reach their goals with regards to intimacy. So I would say to men, don't let the fear of losing that prevent you from getting the care that you need. I mean, one could argue what is more important, but I think that's an individual thing.
All
but
right.
yes, it can have an impact on one's abilities.
Thank you so much, Dr. Shabazz. We have about 2 minutes left, so I want each of you to leave our listeners with something you'd like for them to know.
Okay. I'll just start off first. I'll let everybody else kind of chime in afterwards. I would say, chiming back in on this issue of how prostate cancer if you have it and the treatment could affect your sexual intimacy. I think that would be the best answer to that would be early detection. Because if you get it early, you don't have to worry about it. At least if that is your focus of life, I like living. So, I want to know if I have an issue, I want to know it early enough so I can get it fixed, hopefully, and keep living and doing the things I enjoy doing in life. So the sexual activity is very important. It's just I like life better. So but if it's impacting me that much, if I get it early enough, I can roll.
Okay. Dr. Shabazz, we have about a minute left.
No, I agree with Dr. Newby's statement 100%. There has been some recent media attention about whether or not we should continue to screen for prostate cancer. And my answer is, especially among men of color, African American men in particular, we definitely need to keep it going, keep getting the screening and early detection, because I can remember a time when African American men were not getting screened, and we were seeing these men coming in with far advanced disease. So I would say ignore any of the hype that you hear about how it's not that important. We really don't need to be screening. My answer is we need to continue to screen. The only way to prevent having advanced disease is to get it caught or diagnosed early. So my message is keep on screening for prostate cancer, keep on doing the screening for colorectal cancer as well.
Okay, Charlie, we're out of time, but I want you to say something.
Know your numbers and wear blue for prostate cancer.
All righty. Thank you so much, gentlemen. We really appreciate it.
Hi, I'm Daphne Maxwell Reed, and if you'd like to have another insightful conversation about the African American community, join us on Another View, WHRV 89.5.
For many students, their dream of learning to play an instrument or training with professionals often falls by the wayside because of cost. But thanks to a local program that makes music education both fun and affordable, their dream of studying music is now a reality, and it's called Soulful Techniques.
Look at me.
15-year-old Giovanna Colazzo has been singing as long as she can remember.
Well, my mom always told me that I used to sing, or I knew all the words to most everything on the radio. So she said I was about 2 when I started singing.
Giovanna joined the Soulful Techniques family a little over a year ago, and that's when she really noticed a difference.
I'm a vocal student. I've been there about 1.5 years now. Everything about it, just from the friendliness of everybody there to actually what you're going to be doing in the studio, it's more than what you'd expect. So it's really fun there.
Now she dreams of one day singing in Madison Square Garden. Soulful Techniques began a little over 2 years ago, launching programs for children from kindergarten through high school. The courses last from 6 to 32 weeks. The program is the brainchild of Jazzaray Mitchell. She says the shorter classes allow students to experiment and determine if it's the right fit.
Giovanna started out with an 8-week course. Ariana started out with the 6-week course, and then they move on to a longer-term course. So our goal is to continue their growth. The way that we set up classes, there's a vocal 101. It's building the voice. They start off that way, and then they move on to our 102s, our 103 courses, our 104s, and et cetera, et cetera. And that's the same with our guitar courses.
15-year-old Ariana Miller says she always liked listening to the background music performed by her favorite bands. But thanks to Soulful Techniques, she now dreams of one day playing in a band.
I've liked playing the different songs that they had in the booklets because I've really enjoyed learning how to read the music.
They can start from 6 weeks, which are our teaser courses. And that's typically where we try to get the parent, the student, or the adult student to see if they're acclimated to this, if they like it, if it was what they thought it would be, if it's going to be too hard for them, or if it's going to be a perfect fit. But classes range all the way up to 32 weeks.
Mitchell is also the general manager and founder of Music Theory Studios, a premier recording studio located in Virginia Beach, which allows students to also train alongside an engineer or to participate in their DJ Academy.
My goal was to be able to provide for, families, single family, well-off families, whatever it may be, an option to provide their children or as adults an opportunity to learn the actual theory, the intense education of music and art without feeling like they have to get a loan to do so or without breaking the bank. So we try to find affordable options with payment plans that assist the parent or assist the adult student that would like to take our classes.
David Hott teaches guitar. He says the idea is to make it look easy, but he always encourages his students to speak out when they don't understand something.
So I say, be sure that you're willing to tell me when I haven't explained something right, because I don't consider you're not understanding something I went over your failure as a student. It's if you didn't learn it, that means I didn't teach you. I didn't do my job. So I like students that are able to communicate with me. It makes all the difference in the world. The moment you start taking that lesson and you get serious about it and you say, I really want to do this, you're becoming part of the musical community.
And it's an experience students like Giovanna and Ariana will never forget. For more information on Soulful Techniques, you can visit their website at musictheorystudios.com or give them a call at 757-961-6202.
You will be my Saturday love.
Things to view and do in Hampton Roads. The Universe Soul Circus will be at the Gallery at Military Circle in Norfolk from June 28th through June 30th. Tickets can be purchased online or at the door. Call 1-800-316-7439 for more information. The Virginia Historical Society presents a new exhibition called Revolution: Songs of Social Change, which takes a comparative look at the songs from the 18 and 1960s. It opens tomorrow, June 29th, and will run through December. For more information, call 804-358-9. I'm going to do this number right. 804-358-4901. There you go. The Garden of Hope invites everyone to the African American Impact Fair this Saturday, June 29th, from 9 a.m. to 3 p.m. at the Hunton YMCA, right here in Norfolk. Come out and participate in the Family Fitness Walk, ask questions at the Doctor Forum, and see over 30 vendors at this free event. For more information, call 757-390-4328. Do you really want cheap books? Accomack Main Library will be selling the books for 50 cents to $2 on July 4th from 9 until noon. Book bags are available at a discount, or you could buy $20 worth and get one book free. For more information, call 781-3400. The Virginia Minority Supplier Development Council is holding a business opportunity fair. The event will host various national speakers and give attendees access to vendors. The fair is on July 10th from 8 until 10 p.m. at Christopher Newport University. Call 804-788-6490 for more information. These events and more are on our website, anotherview.org, anotherviewradio.org. If you haven't already, please sign up for our eView newsletter, a once-a-week reminder of upcoming shows. Thank you for spending your noonday hour with us. For producer Danny Epperson, who so graciously agreed to fill in for me, audio engineer Perry Smith, and Kira Dunstan, who answered our phones. I'm Lisa Godley. Be sure to tune in for our special Poetry Jam Encore presentation next Friday at noon, when we'll get together again for another view.